very glad to announce that travel has not stopped Professor Rohini Sharma. And so she has arrived just in time, and Shahid compliments because we were also perfect in time. So please, Professor Sharma, please give us a talk about CCA.
Thank you very much, and apologies again for being late, and thank you, Shahid, for stepping in for me. Thank you very much, AMMF, for inviting me today. This is the first time I've spoken at the conference, and it's very exciting. So I'm really looking forward to the rest of today. So my talk is quite difficult. What is cholangiocarcinoma? So I appreciate that there's actually quite a lot of talks about the molecular markers and the pathology, in particular the drugs that we now have, so I'm not going to talk about that. I'm going to talk more a little bit about the incidence, the coding issues, which I know Professor Khan has spent a lot of time looking at, as well as the risk factors for cholangiocarcinoma, and giving you a very global overview about what is cholangiocarcinoma, knowing full well that I'm talking to an educated audience. So just to start off with a very generic outline. So it's an epithelial malignancy, and it can occur anywhere along the biliary tree, and I'll talk more about the different subtypes of the cholangiocarcinoma in my next few slides. It's thought to be a rare cancer, but in saying that, the incidence is increasing, and we'll also go into that as well. It makes up 3% of all GI cancers, and after hepatocellular carcinoma, it is the next most common primary liver cancer. However, it does actually make up a large proportion of all deaths from GI malignancy, so 20% of all cancer-related deaths relate to cholangiocarcinoma. The peak age is supposed to be in the 7th decade, but some work by Professor Khan suggests that this might not be the case, and I'll show you that as well, and it has a slight male preponderance. So when we think about cholangiocarcinoma, I think it's really important to take a step back and think about the anatomical classification. And this is really important because you almost can think about cholangiocarcinoma as three distinct diseases based on the anatomical classification. So the first group are the intrahepatic cholangiocarcinomas, and they start above the second-order bile ducts and the small bile ductules up here. We then have the perihilar cholangiocarcinomas, and they start in the common hepatic duct involving either the right or the left hepatic duct. And the distal cholangiocarcinomas will start below the cystic duct. It's kind of like the anatomical demarcation. And what I've shown you here also is the spread of the different tumours. So the least common are the intrahepatic cholangiocarcinomas, which range from about 10 to 20%. Perihilar make up 50 to 60%, while the distal cholangiocarcinomas make up 20 to 30% of all the cholangiocarcinomas. I think what's also really important, though, is that when you look at it from a histological standpoint, you can actually break this down further. So the intrahepatic cholangiomas can be broken down further into a small duct type and a large duct type. And this also can impact the way they present. So the intrahepatic ones can present either as mass forming, where you have a discrete lesion, a periductal infiltrating, where it infiltrates along the ducts, and you also can get a combination of both periductal as well as a mass forming lesion. When we think about the small duct intrahepatic cholangiocarcinomas, these are quite distinct from the large type in that these harbour quite distinct mutations. They have mutations in IDH1, IDH2, and FGFR fusion mutations. It's thought that these particular lesions actually arise from the hepatic stem cells or the progenitor cells and the ductules themselves, as well as the cuboidal cholangiocytes. And most of these cancers arise on a background of chronic liver disease. On the flip side, with the large type, these tend to harbour KRAS and TP53 mutations and arise from the cholangiocytes per se. These tumours are more associated with chronic inflammation, usually due to PSC, so primary sclerosing cholangitis, or liver fluke infestation. So I think what's really important, like I was saying before, is I do think these three different subtypes have quite distinct epidemiology, pathology, and management. And like I said, I won't go too much into the management, but I think it's really important just to highlight particularly those molecular mutations, because as we know now they tend to govern how we manage this cancer moving forward. So just alluding to what I was saying to you before, the risk factors for these different cancers are quite different. So for the intrahepatic cholangio, like I was saying, it's mainly cholangitis as well as the background cirrhosis, so liver disease, while for the extrahepatics, which include the perihilar and the distal, it's liver fluke infestation and the cholangitis again. And this just goes to show this is like a slide looking at the age standard mortality for cholangiocarcinoma. And you can see there's actually quite a geographical variation in the mortality figures for the whole world. So yellow indicates a low mortality, this is 1 case per 100,000, while the orange is an intermediate mortality where there's 1 to 2 cases per 100,000, and red is a very high mortality. I think what's really important is where we are currently has a high mortality level. But I think what's also missing from here is we don't have data here on China or on Thailand, and that's because a lot of this information isn't available. On this particular graph, what you can see here is instead of actually commenting on the mortality in these countries, they've commented on the incidence. And these countries have very high incidence of cholangiocarcinoma because of liver fluke infestation. It's often in the food, so having a raw fish that's infected by the ova of the parasites will cause the cholangiocarcinoma, and that's one of the reasons why it's endemic in these countries. And there's quite a lot of really interesting public health work, particularly going on in Thailand, about trying to reduce the infestation as well as reducing the incidence of this disease. But I think that's actually quite interesting when you're thinking about mortality rates, when you're looking at a global picture, that actually in the countries where there's very high incidence, we don't have very good, reliable information. And this is, again, really highlighting what I was saying about the epidemiology, is that actually the highest incidence is most likely to be, is in Thailand, effectively. And this is telling us that there's 85 per 100,000 people are infected, have cholangiocarcinoma due to that infestation by the liver flukes. And I'll show you another slide here. So this is actually indicating now the odds ratio of developing cholangiocarcinoma, so what your relative risk is of developing cholangiocarcinoma based on all these particular risk factors. And I think one of the ones I wanted to point out, because this is actually probably one of the greatest risk factors, particularly in our country, is primary sclerosing cholangitis. And you can see here that those that have primary sclerosing cholangitis have an odds ratio of 15% of actually developing cholangiocarcinoma. And then we've got some, like Shahid was saying before, cirrhosis, chronic hepatitis B, hepatitis C. And I think what's also interesting is I'll show you some slides where there's an increase now in the incidence of cholangiocarcinoma. And it's whether or not this is actually affiliated with the increase in what we're seeing now of non-alcoholic fatty liver disease and type 2 diabetes, obesity, and hypertension, all of which are increasing in our society and all of which are increased, these people are at increased risk of developing cholangiocarcinoma as well. And again, this is just, I wanted to again highlight the point that there's different risk factors for the different subtypes of cholangiocarcinoma. Whilst there is some overlap, I think it's really important to consider these different risk factors. So we know that choledochal cysts, for example, are associated with both intrahepatic and extrahepatic. Cirrhosis, like I mentioned before, tends to be more associated with intrahepatic cholangio, while in Eastern countries, it's mainly cirrhosis and hepatitis B that confers a greater risk of intrahepatic cholangio than in the West. And like I was saying before, this increasing rise in cholangio may be associated with type 2 diabetes, cirrhosis, alcoholic liver disease. I think what's really important to realise, though, is that in the majority of cases, we still do not understand why someone has developed the cancer in the first place. There's no known risk factor. And this is important because it makes it really hard then when we're thinking about screening programs and surveillance. If we don't know what the risk factors are, how can we then employ a public health measure to try and pick up these cancers early? I think that's something really important just to think about. And thinking about what Shahid was talking about, HCC, that's one of the key differences, I think, in HCC and cholangiocarcinoma, is that with HCC, we know people have a background of chronic liver disease. They can have 6-monthly ultrasounds. The idea is we try and pick up cancers early. And certainly in some cirrhotic patients, having those ultrasounds will pick up cholangiocarcinomas early as well, but we don't have a dedicated program in terms of knowing who the at-risk population is. In saying that, like I mentioned before, people that have primary sclerosing cholangitis are at a very high risk of developing cholangiocarcinoma. For those of you who don't know, PSC is an autoimmune disease, and it's characterised by destruction of the intrahepatic bile ducts, inflammation and cholestasis. And we know that in general, when we've got chronic inflammation and biliary stasis, that's what increases the risk of developing this particular cancer. The annual risk of developing cholangiocarcinoma on a background of PSC is 0.5 to 1% per year, and this is 400 to 600-fold increased risk compared to the general population. So these people are exceptionally high risk of developing cancer. What is interesting is that 1/3 of people are diagnosed with a cholangiocarcinoma within 12 months of being diagnosed with PSC. And there's suggestion now, particularly from the EASL guidelines, that we should be doing annual surveillance in people who have PSC with both an MRI and MRCP. And I wanted to just reference Shahid's study, which I think is really important. And the idea of this study is whether or not giving people who have a diagnosis of PSC aspirin, and does this reduce the incidence of developing a cancer per se. So these are for patients who have a history of PSC, IBD, and they need to be with at least 12 months of diagnosis with no evidence of cancer. And it's a double-blind randomized controlled trial. Patients will be randomized to either aspirin or placebo for 5 years. Professor Khan's looking at randomizing about 1,000 patients, with the outcome being cancer outcomes, listing for transplantation, and all-cause mortality. Like I said, I think it's a really important study, because if we can reduce that risk of developing cancer, I think that will have a big impact on what happens in our future incidences. And this is an important graph, which essentially highlights the fact that there is an increase in liver cancer per se. And unfortunately, in a lot of the studies, liver, as in HCC, and cholangio have been lumped in together, which makes it quite difficult in terms of teasing out. But I'll go through some of the data that Professor Khan and the AMMF have created. So you can see here that from 2016 to what the projected incidence is, there is an increased incidence in this particular type of cancer. So what we know is that intrahepatic cholangio rates are increasing, but extrahepatic cholangio rates are supposed to be decreasing. So overall, there is an increase. But is there really an increase in intrahepatic or ductal or periductal? It's a little bit confusing, and we need to find, one of the pieces of work that the AMMF have done, as well as Professor Khan, is trying to work out, why is there this change in the incidences? Is it because we're getting better at picking up these cancers early? Is it increasing awareness, or is it coding? And what the team have found is it's essentially coding. So what do I mean by that? So this is a paper that was published by Shahid and his team. So they looked at cholangiocarcinoma cases, and they reviewed all the cases by 2 independent clinicians. They looked at MDT notes, imaging, and clinical notes. And they looked at 3 independent regional centres between 2015 and 2017. And they did a retrospective diagnosis and compared this to the original allocated ICD code. So what is an ICD code? So all cancers are given an international code to tell you what type of cancer it is. And this code is really important, because this is the way we find out what the incidences of different cancers are, and we can track how cancer rates are changing, we can track mortality rates, we can track treatment rates, and that's what every cancer is given a code. And there's been changes in the way that cholangiocarcinoma has been coded, and that's probably the reason why there's been a change in the incidence of cholangiocarcinoma. So what Professor Khan found is when they looked at 625 cases, 226 were coded as intrahepatic cholangio. Of these, 43% were actually true intrahepatic cholangio, cholangiomas in that they were coded correctly, but actually 34% were actually periductal, so they were coded incorrectly as intrahepatic. So that's actually a really important point, is that this idea about incorrect coding can impact the incidence rates that we're seeing. And this is actually just showing you the actual correct coding across the different centres. And again, this is work done by Professor Khan as well, again showing there's been a change now in the coding to actually look at the different 3 subtypes. And you can see that since that's happened, there's been obviously a dramatic change since the introduction of that code in the incidence of the intrahepatic and the extrahepatic cholangiocarcinomas. So coding has had a really big impact on the incidence that we're reporting. One of the other things I thought was really interesting was work again done by Professor Khan and the AMMF, was looking at socio-economic and temporal variations in England. And this is something that I'm actually really interested in as well from an HCC point of view. So what they did is they looked at data sets maintained by the National Disease Registry. So they looked at the National Cancer Registration data, systemic data therapy, and hospital episode statistics. And they looked at tumour and patient characteristics. And they looked again at incidence and mortality across a 16-year period. And again, what you can see here is that there is an increase in the incidence of cholangiocarcinoma, which is indicated here across the timelines. And what I think is really interesting is that there's an increased incidence with deprivation levels. And this is not just limited to cholangiocarcinoma. We see this in HCC as well, that the more deprived areas have high incidence of these cancers. And I think what's really key is they also have higher mortality rates as well. And this has been shown in cholangiocarcinoma as well. So what Professor Khan showed is that 39% of the most deprived group had a higher incidence of cholangiocarcinoma, and there's also a much higher mortality rate of cholangiocarcinoma once they were actually diagnosed as well. And I think that's actually, it speaks a lot for what we need to do in terms of equality and equity of healthcare services. And like I said at the start, initially when I was reading about this, and when you read everything, it says that it's a disease of the elderly, but actually work from the AMF and what Professor Khan has shown is that 22% of patients were actually diagnosed at less than 65 years, and men tended to be diagnosed younger than women. And this is what's illustrated in these bar graphs here. I wouldn't be a professor at Imperial if I didn't put up molecular imaging. So this is just to show what all the signalling pathways are for cholangiocarcinoma. So it's a very complicated disease, and you've got numerous signalling pathways. The idea is that there's a lot, again, of uncontrolled inflammation, particularly driven by the IL-6 STAT3 pathway. And I think the other key pathways, just to point out, is the Wnt signalling pathway, which activate the RAS-MAP kinase pathway here, and the PI3 kinase pathway. What is common to all cholangiomas is the RTK pathway. And all these pathways essentially result in uncontrolled proliferation, stops apoptosis, so stops cell death. There's tumour growth and migration and invasion. What is really interesting is that a lot of these now are druggable targets, and as Professor Khan had shown in that excellent diagram, is there's lots of new drug targets that are coming out looking at these different pathways. And I think there's a talk coming up based on the fusion pathways as well as the IDH mutations. What hasn't been really discussed, and I think is also really important, is the tumour microenvironment. So we do know that cholangiocarcinoma has a very strong stromal reaction, which is very much driven by the cancer-associated endothelial cells and cancer-associated fibroblasts that are here. And this results in a repressive tumour microenvironment, as well as attraction of increase in inflammation, attraction of cells that are not very helpful. So these T regulation cells, and altogether, I think it's not just about targeting the cancer, but I do think that the tumour microenvironment does represent another potential therapeutic pathway as well, because we do know that these fibroblasts are associated with tumour growth and poor prognosis. Professor Khan's already touched on genetics, so I won't go into that. And again, this is just really to highlight that when people have looked at the different subtypes of the cholangio, the mutations are different. So again, highlighting the fact that these are probably different disease entities that we should be thinking about rather than lumping them all in together, which we don't do, but I think it's important to know. In terms of clinical presentation, majority of patients present asymptomatic. Otherwise, people that have the peripheral or the distal will present with jaundice, cachexia, abdominal pain, malaise, nausea, and weight loss are common. Investigations to diagnose cholangio include CT, MRI, MRCP, FDG PET, which I'm sure the surgeons will talk about, tumour biopsy, and next-generation sequencing is becoming more and more important. And I'll finish with just by putting up the consensus statement based on the treatment guidelines, which I'm sure will be discussed in moving forward in some of the other talks. But just to say that when we talk about resectable disease, it's only a small number of patients that actually have resectable disease. And Professor Khan talked about the role of adjuvant treatment. The bulk of patients will have unresectable disease, and this is actually a really exciting area now in terms of the different types of treatments that are now becoming available, including combination immunotherapy and the targeted molecular markers. So thank you very much, and I'll stop there.